So good evening all. Welcome everyone to the PG case presentation series conducted by IRIA Kerala in association with JournoMed. And towards this, I welcome Dr. Gomadi Subramanian, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Anai, Program Coordinator. And today the PG case presentation series is moderated by Professor Rajesh Kannan, Amrita Institute of Science, Medical Science, Kochi. I welcome Dr. Rajesh Kannan. And now over to Dr. Rajesh Kannan for starting this program, and also welcome the participants who are the residents who are actually participating in this program. Thank you. Now over to Dr. Rajesh Kannan.
Thank you, Venu sir. Good evening, all students. So today we are having 3 PG case presentations. So it's 3 interesting cases. Which may be some of the case may be little rare for the residents. And but these are all very classical cases. What we are going to discuss, we are not showing very rare or unknown cases. It's the common cases, but what we are going to show is how to approach those cases. And our 3 PGs are going to have the case presentation followed by discussion of those cases. And while doing the case itself, we'll have a whatever queries can be answered during the session. So I request all the delegates to send their queries so that we can answer it during the case presentation. So we'll start with the first case. I request Dr. Prasant. All 3 are the final year PGs. So all 3 cases are based on the CNS imaging. Yeah, we'll start with the first case.
Okay, I'll share my screen.
Share your screen.
Yes. Yes, I just would like to wish all the faculty and my colleagues a good evening. And I am Dr. Prashant Rajan, PG resident, and my topic today is how to approach suprasellar mass. So today we have my patient, a 25-year-old male, had presented with persistent headache. That is the only significant clinical history. So an MR was taken because the headache was persistent for more than 2 years. So the patient got concerned and MRI was taken. So this is these are images of T2 axial of MRI brain. So basically, I'll just try to describe the findings on each sequence and give DDs on that. So here, as we can see in these multiple sections, there is a mass located most likely in the suprasellar region. Considering the other images, there is not much extension into the cella in the present axial images. And if I want to describe this mass, it is a well-defined circular mass with central T2 hyperintense areas and peripheral T2 hypointense areas. And the mass is seen abutting this is the midbrain and the cerebral peduncle, abutting the left cerebral peduncle. Anteriorly, it is in contact with the middle cerebral artery, and also it is also abetting what looks like to be the optic chiasma. So, move on to the next slide. This is a T1 weighted axial section of a brain, and the previously described lesion that was there is now in the same location, and it is also showing T1 hyperintense areas in the middle and T1 hypointense areas in the periphery. So based on T1 and T2, I would like to give a differential diagnosis of meningioma, because meningioma, craniopharyngioma, or a teratoma. So based on further sequences that will be provided, these differential diagnosis can be narrowed down And also I would like to give a differential diagnosis of, because this is where the internal carotid artery is also, aneurysms can also be a valid differential diagnosis. Here we can confirm that the lesion is an extraaxial lesion. This is a coronal T2 section of the brain, and here we can confirm that there is it is an extraaxial lesion because we can see the buckling of the neuroparenchyma, and so this is most likely to be an extraaxial lesion, and it is showing central T2 hyperintense areas with peripheral T2 hypointense areas. So actually, I would like to speak a point about craniopharyngioma. If we were thinking of craniopharyngioma, we would be thinking that there could be proteinaceous materials or cholesterol.
Prashant, yeah. So before going into the pathology proper, so first of all, we'll look at the tissue characterization of the given lesion. So one is the lesion shows areas of hypointense signal on T2.
Yes, sir.
So most of the pathologies what we know of will show hyperintense signal on T2.
Yes, sir.
So if it is showing hypointense signal, so what are all the different tissues which can appear dark on T2 weighted image?
So calcium can appear dark on T2 weighted imaging.
Yes.
And then even fungus or fungal balls can also appear dark on T2 weighted imaging. Then even no fat will appear. Even like mucinous material or proteinaceous material can appear dark on T2 weighted imaging.
Yes.
So these are few of the substances that can appear dark on T2 weighted imaging. And even if it is blood, also intravascular blood will also appear dark on, because slow voids, mobile blood, intravascular blood will also appear dark on T2 weighted imaging.
What about the bleed?
Bleed, yes, an acute, hyperacute bleed will appear dark on T2 weighted imaging.
Not hyperacute, yeah, acute to early subacute.
Early to
Both deoxyhemoglobin and the intracellular methemoglobin. What about chronic?
Chronic also will appear dark. Hemosiderin is also dark.
Hemosiderin. So all
Hemosiderin
three is, so basically deoxyhemoglobin, intracellular methemoglobin, and the hemosiderin. All three will appear dark on T2. Okay.
Yes.
So the fat usually will appear bright. Fat won't appear dark on T2.
Yes, sir.
Then any other substance can appear dark on T2. Melanin can appear dark. No,
Melanin.
No, you told. Yes. So common things are the blood products, then the high protein material, then calcification, flow voids. Rarer things include the melanin content. So that's what we'll see it appearing darker on T2 weighted sequences. Okay. Fine. So then with this idea, then we have to correlate with the location of the lesion.
Yes.
So for the location, it is in the suprasellar, as you rightly pointed out, and it is extraaxial lesion. So yes. Then we can discuss the DDs. Yes.
So my primary DDs would be a meningioma, craniopharyngioma, a dermoid or teratoid, and even blood products like cavernous hemangioma can also be part of my DDs, and also an aneurysm of any vessel that is in that region, like internal carotid or middle cerebral artery. So these will be my DDs.
So yeah, among these, suppose if it is a meningioma, how will you explain the dark signal?
So this could be a meningioma with peripheral calcifications.
Yeah, so generally meningiomas can show significant amount of calcification, so it can appear dark on T2. Whereas if it is a craniopharyngioma,
the craniopharyngioma, what like proteinaceous material, mucinous material appear.
Yes, so high both the protein content can appear because of the high protein, it can appear darker. Then you told hemangiomas, the cavernous hemangioma, generally they will appear very bright on T2.
Very bright.
So, yeah. So,
and dermoid also can appear some tissues.
Dermoid, depending on the content, it can have variable content. Usually it will have a fat content, then it will be easier to identify. Yes. Whereas it can have a protein material sometimes, so that can appear dark. Okay. Yeah. Epidermoid generally again mostly will be bright on T2 unless it contains some other materials.
Okay. I'll move on to the next slide, sir.
Yeah.
So this is a T1 weighted sagittal image. This is also confirming the location that it is a suprasellar lesion. This is a gradient.
Go back. So if we suppose if we see a lesion like this in a pediatric age group, what would be your DD?
Craniopharyngioma.
10-year-old. Yeah, one is a craniopharyngioma.
Then I could take the dermoid cyst, epidermoid. Because not epidermoid, because it would appear bright on T1 because of fat. Even arachnoid cyst can also occur. But this is a T1 weighted image. So arachnoid would be dark on T1 and bright on T2.
Yeah, it's not that dark like a CSF. What else is common in a suprasellar region?
Yeah, glioma, optic chiasma glioma.
Yes, hypothalamic optic chiasmal glioma will be a DD. Now, whenever you see a lesion like this, without any other imaging, I am talking. So based on the location and the age, it's very important. Okay, yeah.
So I'll move on to the next slide.
Next, yeah.
So this is a gradient image, axial section of brain. So there is no significant gradient blooming. So this could most likely.
What does it rule out? So
it rules out the calcification or an acute bleed. So that means meningioma is most likely. I mean, the dark segments are not likely due to calcification, so it's unlikely to be a meningioma with peripheral calcification. Yeah, now this is a diffuse
as well as not a blood product.
Not a blood product.
Not a hemosiderin or anything. Yeah.
This is a diffusion weighted image on my left hand side, and on the right side it is a ADC, apparent diffusion coefficient. So this lesion shows no significant diffusion restriction. So it is unlikely to be a highly dense tumor like an epidermoid or a dermoid cyst. These would all be showing diffusion restriction. Even meningiomas can also usually show diffusion restriction. This lesion is not showing such a pattern. So these diagnoses are unlikely.
Yeah, in fact, you can say that it's showing a facilitated diffusion. It appears dark on diffusion and the very bright on ADC. Okay.
Yes.
Next.
This is an axial section of post-contrast image of the brain. So this the lesion is showing intense enhancement in contrast enhancement in post-contrast images. So DDs that would go for this could be a meningioma will show intense enhancement, but our previous imaging sequences were unlikely a meningioma. And anything vascular will also show intense contrast enhancement. For example, aneurysms or hemangiomas will show intense contrast enhancement. This is
so one of the rare DD. If it is in the parasellar location and enhancing very brilliantly will be a cavernous hemangioma. Okay, so that is a vascular malformation, which may almost mimic like a meningioma or a schwannomas can be a DD which are occurring at that location. Which is extending into the cavernous sinus parasellar region. Yeah. Next.
So this is a sagittal section image, a post-contrast image, confirming the location and showing intense contrast enhancement of the lesion. This is a proton density image, and the significant finding in this image is the flow artifact that is seen. This flow artifact is normally seen in vessels and seen in images, but this can be have diagnostic value when you're seeing it as in increased amount in the searcher region. And this increased flow artifact is very common in aneurysms. So this would most likely confirm the diagnosis that this was an aneurysm.
Yeah. So why this is happening only in the transverse section? Why not happening in the anteroposterior direction?
Yeah, because y-axis frequency encoding is taken in the y-axis, so that is where.
Yeah. So the transverse axis will be the which direction it has occurred. The
horizontal. Sorry, phase encoding is y and x. Yeah, phase encoding is y-axis and x-axis is frequency encoding. Yes.
Yeah. So generally in the axial brain, the transverse, the right to left will be the phase encoding direction. So this flow-related artifact always occurs on the phase encoding direction, whereas there are some artifacts which will occur along the frequency encoding direction. Can you tell which
chemical shift
artifact will occur? Yeah, chemical shift artifact. Now it will occur along the frequency encoding direction. So that will also again appear as one area appearing brighter and opposite area will appear dark. But it won't extend beyond the lesion. It will occur only along the margin of the lesion. Whereas here, can you show the pointer? It is extending from almost right end to the left end. Yeah. So the full. So that suggests that this is a flow-related artifact. Yeah. Occurring along the phase encoding direction. Yeah. So
So
it confirms that this is a very sort of a turbulent flow occurring.
turbulent flow.
Okay.
Yes. So basically, the first step in identifying any lesion is the location. So once the location is identified, then we can narrow down a list of diagnoses, which I've already provided. So meninges, we can have meningioma, carotid artery in that region, ectasia, aneurysms, cavernous sinus, as I mentioned previously, schwannoma, hemangioma, and from the suprasellar indenting into the cella, could be craniopharyngioma. So this was mainly a suprasellar mass. There was no sellar extension. So that will also go against the diagnosis of craniopharyngioma. The discussion, as we already discussed, it's an extraaxial lesion, shows T2 hyperintense and T2 hypointense. And corresponding areas are T1 and hyperintense and T1 hypointense. The lesion shows no diffusion restriction or radiant blooming, like we've already discussed. And lesion shows intense enhancement on post contrast images and flow artifact, predominantly seen on the proton density images. Now, this is an MRA angiogram, contrast angiogram. So as we can see, there is a large saccular dilatation, most likely seen in the left internal carotid artery. So confirming our diagnosis of an internal carotid artery aneurysm. The remaining vessels appear to be normal. These are images of digital subtraction angiography done via fluoroscopy. So as you can see on my on this side, this is the normal internal carotid artery on the right hand side, which is not showing any sort of abnormal dilatation. So this is going to be the internal carotid artery, which is then later bifurcating into the anterior cerebral artery, which is going superiorly, and the middle cerebral artery, which is going laterally. And on this side, we can see there is this is the internal carotid artery on the left hand side, and approximately in the ophthalmic segment, the communicating segment, there is a large saccular dilatation of the internal carotid artery. This is, I think,
that one small. Yeah, go back. Previous slide. Can you go back? Yeah. So there is a one more dark area seen below the big aneurysm, no?
Yes, sir.
The angio DSA. Yeah. What is that? People generally mistake that also for an.
No, sir. I think that is the bend of the artery.
On the right side also.
Yeah, it is. It is the bend. I think.
On the right side, normal side.
Yeah, this is the normal side.
The cavernous ICA, where it has a posterior bend and the anterior bend. So that is overlapping in that view. Okay.
Yes.
So if you want to unloop that, you have to take a oblique view. So that you should not mistake that for an aneurysm. Very important. Okay. Yeah.
This is the delayed view where you're seeing the sinuses. I'll show you the oblique view. Yeah, this is the lateral view. So here we can clearly see, and as sir said previously, that bend or the overlap will be differentiated here. So this is the right ICA over here, right ICA, and this is going to be the ECA on anteriorly. So the ICA is going inside, and you can see on this side, as you can see, there is a saccular dilatation that is pointing backwards or posteriorly. So that is why this is not going to be in the ophthalmic segment. Over here is the ophthalmic artery that is going anteriorly into the eye, arising from the internal carotid. So after the ophthalmic segment, you will get the communicating segment. Hence, this is a saccular aneurysm, most likely arising from the communicating segment of the left internal carotid artery.
So it's very important. So when you are looking at the angios, you have to say that from where it is arising. So the direction of the vessels will be very helpful. So a simple difference between ophthalmic artery, because these are all very close, they are not very far. So if you want to differentiate ophthalmic or apicum or an anterocoroidal, so you have to look at which direction the aneurysm is pointing. Okay.
Yes.
Yes. So what is this image?
So this is a right ICA cross compression digital subtraction angiography. So in this, what has been done is that the left ICA is being compressed and occluded, and you are seeing the collateral flow via the anterior communicating artery from the right internal carotid artery traversing through into the left MCA and left ACA to confirm that the blood flow can be can occur even if the ICA is occluded, in case that where they have to ligate the artery to prevent any massive bleed, because one of the most common complications of these aneurysms, and it's very deadly, also fatal it can be, it's a rupture. So in case they need to ligate in case of an emergency, they always want to know that if the collateral circulation will take over. So hence a very important imaging of cross compression is done.
Yeah, so I think, yeah, we can stop.
Yeah, this is just for academic purposes. This is a DCA of the vertebral artery. So in technically this what DSA was done here is 4 vessel, but technically you can do it as 3 vessel, because 1 vertebral artery is enough if you can inject, and which you can reach the posterior circulation. So this will be the left vertebral artery arising, and then forming the basilar artery, and basilar artery is again bifurcating into the right and left posterior cerebral. Here arising from the vertebral artery on this side, I think will be the pica, and arising from the basilar artery will probably be ICA, followed by the superior cerebellar, which is over here.
Yeah.
And this is on a lateral view.
Yes.
Yes.
Yeah.
So this is again.
So thank you. Yeah, good, Prasant. So the importance of showing this case anyway. Yeah, so people can read about the different segments of the angiography and all. So the importance of this showing this case is to approach a case of a suprasellar lesion, and you have to keep all the possibilities. You should know what is the common lesions occurring at a particular age group. Then you have to look at the exact location of the lesion, then the MRI characteristics, whether it has a T1 bright signal, T2 dark signal, and the enhancement pattern, how is the diffusion images and the gradient images. So you put all together, and don't forget to think about the aneurysm, especially if it is a patent aneurysm showing a turbulent flow. Then we can easily diagnose even on a plain T2 weighted image itself by demonstrating the flow related artifact. And also you should know the DSA, how it is done, and the different features of the aneurysms. Yeah, so with that, we'll conclude this. Thank you, Prasant. Can you stop sharing your screen?
Yeah.
So we'll move on to the next case. Can you stop sharing? Yes. Thank you, Prasant. So we'll have the second case. Ashwin, can you show the second case? So meanwhile, I'll request other students, those who are having any doubts, or you can send their queries in the QA section, so that can be answered. Yes, so the second case going to be based on interesting case of proptosis by Dr. Ashwin. Yes.
Yes. Good evening, everyone. Today I will be presenting a case on proptosis. So, as a brief clinical information, a 58-year-old gentleman presented with gradually progressive bulging of the left eye, along with decreased vision and associated double vision since about 3 years. It's the frontal radiograph of the skull. In this, we can see that the left superior orbital roof appears destroyed. We are not able to see it. Also, when you look at the left frontal sinus, it's a more uptake compared to the right side. CT was taken.
No. Based on this, what will be your interpretation? Go to the X-ray. Yeah, go to the X-ray. No, so the X-ray.
Yes, sir.
Yeah. So how will you interpret that?
Sir, we'll be thinking of lesions that are eroding the bone, eroding the orbital wall. So it can be any vascular lesions or nerve sheath based lesions like schwannoma or
No. Generally, when you see a lesion like this, you won't think of a sonoma. It's very rare. Common things in old age, and if you see destruction of the bone, I will commonly think of either a metastasis or the local bone tumor which is eroding like meningiomas, those things, not the sonoma. Okay. And what is bare orbit? Do you know what is bare orbit? That is a feature usually more common with the neurofibromatosis, one of the typical feature of a NF1 is bare orbit, where you won't see this oblique line of the orbit. Can you show the oblique line? Oblique line, lateral to that, lateral, just no, not that. Oblique line going across the orbit, no? That is the lateral wall, what you are showing.
Yes, sir.
Oblique line is little medially one oblique line going around across the globe. Yeah, go up, up, that one. So that is formed by the greater linguosphenoid. Okay, so that will be absent in the case of NF1. It's due to the sphenoid wing dysplasia, which is a very common exam spotter, and I will get it. But this is unusual, to have a erosion or absent superior border of the orbit. Okay. So generally, when you see a lesion like this, without any definite history, you'll think of some mass, bone destructive mass, like a metastasis, one of the common cause which can involve that region, or a meningioma eroding the bones which are well known to occur at that location, basifrontal regions. Okay, yeah. Next, CT.
So CT was taken. This is the axial view. You can see a relatively well-defined hypodense lesion in the left orbit, and it's extending posteriorly, widening the superior orbital fissure and thinning the body of sphenoid and also eroding the clinoid. This is the coronal view.
Go back.
Coronal, you can see that
We'll
the
go step
roof
by
of
step.
orbit is
Aswin, can you go back?
Ah,
Axial CT. Go step by step. Yeah, you told there is a proptosis, no? So what is the criteria to call that as a proptosis? Can you show that? What criteria we use to
proptosis.
proptosis?
We usually we draw a line from the anterior to the sphenoid.
What is that called?
And then
that line is called interzygomatic line.
Interzygomatic line, sir.
Sorry,
Zygomatic line. Yeah. And then you measure the distance from that line to the anterior surface or the posterior surface of the globe. So from the distance from the line to the anterior surface, if it's more than I think 23 mm, we call it as proptosis. And the distance from that line to the posterior surface of the globe, if it's less than 5.9 mm, we'll call that also proptosis.
Yeah. So here it is definitely, we can say that the entire ball is well anterior to that interzygomatic line. Yeah. So in a subtle cases, that will be very useful. Okay. So based on this, can you say where is the location of the lesion? Next image, can you show the lesion? And an axial CT wise, so where is the location of the lesion?
Location appears to be in the extracornal compartment, sir. Left orbit extracornal compartment.
Why do you say it is extracornal? See, one thing is, yeah, you know that you have seen the CT, I mean, coronal, other things and all, but given images, so even in the exam, this is, sometimes can happen, where you may get both the CT, MR, X-rays, everything together, and you know what is the diagnosis. But when you are presenting, based on the given image, you should know what is the finding, and you can keep changing the findings as we have more and more images. So that is absolutely fine. But based on the given images, can we say that it is intracornal or extracornal? Where is the location?
It's difficult to say based on the
how to say
axial
which
images, sir.
distinguish intraconal or extraconal lesion. So what finding you have to look for?
So the widening of this superior orbital fissure.
Okay. And I am asking whether can this be an optic glioma? Why not optic glioma? That also, if it is a very big and can erode the bones there, isn't it? So can you able to see the optic now in an axial? That's what you have to look
Yes,
for when
sir.
you are seeing a mass. Okay, so can you show that image? So when you are now, sometimes people can mistake an superior or inferior rectus muscle for an optic nerve. So what you are showing one straight structure which is coming from the eyeball. So it is looking like on the superior part. But sometimes people can mistake a superior rectus or an inferior rectus muscle also will appear relatively straighter, that you should not mistake it for an optic nerve. So the best thing will be looking at a coronal section. But here, if that it is the optic nerve is seen separately and the lesion is above the optic nerve. So that's why what we are thinking. But still difficult to say whether it is intraconal or extraconal unless we see the superior rectus muscle separate from that. So based on this, you should not call those things. We have to say that it is an intra-orbital mass, predominantly a retrobulbar mass extending into the cavernous sinus region. Okay, yeah, next.
Yes. It's the coronal sections, sir. This you can see that the mass is compressing and displacing the optic nerve, extraocular muscles, and the globe inferolaterally. Also, you can see the destruction of the superior wall of the orbit.
Yeah. So now, based on this, what will be your diagnosis?
So you can see the optic nerve
So
clearly,
now
so that rules out an.
Yeah, you are seeing the optic nerve clearly. So what does it rules out?
That rules out an optic nerve glioma.
Yeah, so the most common retrobulbar masses what we come across in the clinical practice are the optic nerve glioma and the optic nerve sheath meningioma. So both can be ruled out based on this. Okay. So can you say it is intraconal or extraconal?
I can say it's
What do you mean
extraconal.
by intraconal or extraconal?
Intraconal is within this cone of the orbit. So within this cone, we call it intraconal, and outside that it's extraconal. And if it's in the within the border, we call it conal. So
now, within the retrobulbar muscles, okay. So the within the all these superior rectus, inferior rectus, medial lateral rectus, so if it is within the muscle, it is intraconal. Outside the muscle is extraconal. Yeah. So what are the importance of that? Can you enumerate a few extraconal lesions and a few intraconal lesions?
yes, extraconal will be a can vascular lesions can be there, sir. Sorry, vascular cavernous hemangioma is usually intraconal, sir.
Cavernous hemangioma usually extraconal. Only the capillary hemangiomas are intraconal. Okay. Yeah, so the most common masses are the pseudotumors. Okay, so among these masses, what you are come across is I forgotten to mention that the pseudotumors are the most common, and the other close DD will be a lymphoma. Whenever see a mass like this. Okay, so lymphoma will be also a closed DD. You have to look at the other imaging appearances. And the pseudotumor can extend along the muscles, and there I can go and read the difference between pseudotumor and the thyroid ophthalmopathy. Usually thyroid ophthalmopathy won't cause a very big mass like involving isolated muscles. It usually bilateral and involves the multiple muscles. Okay, so that are all now will come as a different diagnosis: thyroid ophthalmopathy, pseudotumors, lymphomas, and all. Okay, yeah. Next, what the next images?
These are the possible differentials, sir. MRI was taken. The coronal T1 section, in which the mass is appearing hypointence to the muscles. And you can see the optic now more clearly.
Actually, the superior rectus muscle is not seen separately. It's very difficult to say whether that is involving or separate from that. But here the important thing is it is extending beyond the orbit, okay, into the cavernous sinus region.
Yes,
So
sir.
it cannot be a involving
Yes,
just the muscle. So because muscle stops in the orbital
Yes.
itself, here it is going beyond into the cavernous sinus. Okay.
Yes.
Next.
The coronal T2 weighted images in which the mass is appearing heterogeneously hyperintense.
Can you go slowly? Actually, I think there is a lag. So some of the images looks like skipping. Go little slowly, so image one by one. Yeah. Okay. So this is a T2 weighted image.
Yes, T2 weighted image and it's appearing heterogeneously hyperintense.
Yeah. So what is the importance of that? Can this be lymphoma? Because lymphoma would be one of the DD whenever you see erythroblast mass.
Lymphoma usually will be more homogeneous.
Expect the lesion, it won't be so bright on T2 weighted image. It will be more or less isointense, and it will show a relative T2 shortening. Okay, so that's rules out lymphoma. Next. So contrast.
Yes, the sagittal contrast sections. You can see the extent of the lesion more clearly in this, and it's heterogeneously enhancing. You can see a few cystic areas within.
Yeah, stop here. Yeah. Yeah, so here we can clearly see that the lesion is retrobulbar and extending into the cavernous sinus, and it shows a lot of cystic areas and appears bright on T2. So all these findings confirm that this is a schwannoma, maybe arising from any of the 3, 4, 6 cranial nerves, and it's very difficult to differentiate these things, and you have to look at the clinical findings. So the idea of presenting this case is to look at the orbital masses and its different diagnoses, how to differentiate intraconal versus extraconal masses and the pathologies. People generally, whenever you see a long elongated lesion like this, people tend to think that everything as a optic glioma, but you have to think of the other possibilities like a schwannoma also. Thank you, Dr. Aswin.
Yes.
Can you stop sharing your screen? We'll move on to the next case.
Yes.
Yes, Dr. Nupur, can you share your screen?
Yes. Good evening, everyone. This is Dr. Nupur from the Institute of Medical Sciences. I'm going to present case of intra-axial mass lesion. So, a 71-year-old patient who was known case of multiple myeloma and had CAD for which CABG was done. He came with acute onset right-sided heavy paralysis and facial weakness for 2 days. An MRI contrast brain was ordered, and it showed
Yeah, so basically, he's a elderly gentleman who presented with the recent onset of right hemiparesis. So with the clinical diagnosis of stroke, and MRI brain has been requested to rule out or the locate the site of the stroke. Okay,
Yes.
go ahead.
Yes. Uh, so flare sequence showed hyperintense signal involving left thalamus and in left precentral gyrus and left postcentral gyrus. The lesion in left thalamus.
No, go back.
Yes, sir, yes.
We'll go one by one. No need.
Yes, sir,
to
yes.
rush.
Sorry. Okay, sir.
Yeah. So among these, you are seeing so many lesions. You are seeing a lesion one is in the frontal cortex. There is some lesion in the postcentral gyrus. You are seeing lesion in the left thalamus. So among these, first of all, which lesion can explain the symptoms of the patient?
So left precentral.
Yeah. So go to that lesion.
Yes, sir.
Yeah. So can you describe this lesion further?
So this is a T2 flare hyperintense signal involving cortical region of left frontal lobe, specifically in left precentral gyrus.
Yeah. So yeah, it is involving the precentral gyrus, and you have to also see whether it is involving predominantly a gray matter or predominantly white matter lesion. Okay, so or is it just a vasogenic edema type of a lesion? So that's what you have to look at it. And is there any volume loss of the involved segment, or is there any bulge or increase in the volume of the involved segment? All those things you have to describe.
So there is no volume
so
loss.
This is a cortical based lesion. So there is no volume loss, or maybe some full effacement of the adjacent gyri, isn't it? So
Yes,
the
sir.
adjacent sulcus is effaced with. Okay.
Yes, sir.
So when you see a lesion like this, so what will be your diagnosis with the history of hemiparesis?
Sir, first differential would be infarct, sir.
Okay.
Or it can be encephalitis.
Okay.
But encephalitis will be second one, sir. First will be infarct.
Okay. Yeah. So when you say infarct, will you think of an arterial infarct or a venous infarct?
Venous, predominantly venous, sir.
Why?
Sir, because it is not in the territory of artery, first of all, and it's more cortical based, and edema we can.
Yeah. See the arterial infarct, the gray matter will be involved more than the white matter,
Yes.
whereas in a venous infarct there can be a significant amount of white matter involvement because of the vasogenic edema. Okay.
Yes.
So that you have to keep in mind, and areas of hemorrhages are more common with the
Venous infarct.
Venous infarct are generally bilateral. Okay, so involving the high frontoparietal region. Okay, yeah. So these are the things, but these lesions won't explain the thalamic lesion, which is appearing separate. So, but an encephalitis can involve the cortex, thalamus, basal ganglia. So that is a possibility. Okay.
Yes, sir.
Fine. Move on to the next. But the clinical feature is not like encephalitis in this case. Yeah,
Yes, sir. Yes, sir.
also there are lesions involving the postcentral gyrus.
Yes, sir. So then on differential DW sequenced, the lesion in the left thalamus that was not showing diffusion restriction, and also the lesion in left precentral gyrus that was also not showing full diffusion restriction on ADC when we compared with ADC sequence.
No. Go back to the diffusion image.
Yes, sir.
So the diffusion image. So the diffusion of images of the precentral gyrus lesion. Is this a diffusion image?
Yes, sir.
This is not diffusion image, no? The diffusion image, the CSF will appear darker, so that is one way.
Yes, there's actually
This
this
will be
lag.
a
Yes, sir.
diffusion image with a B0 value. Okay.
B0. Yes, sir. This one.
Ah, okay. Yes. So we are seeing a lesion that whatever lesion we are seeing on a flare is appearing bright on diffusion weighted image. Okay.
Yes, sir.
So what are all the different pathologies which can show diffusion restriction?
Infarct,
Okay.
encephalitis again, sir.
Okay.
And sir, metastasis, lymphoma.
Yeah, lymphoma, okay, not metastasis. Metastasis generally wants a restriction with very few exceptions are that. No, if you take say 100 cases of metastasis, maybe 5 to 10% can show diffusion restriction.
Yes, sir. Yes, sir. Not so metastasis. Yes, lymphoma.
Yeah, basically highly cellular tumors, not specific for lymphoma, like lymphoma, meningioma, medulloblastomas. So those are all the tumors can show diffusion restriction. Then see demyelinations can show diffusion restriction.
Demyelination.
If the lesion is predominantly white matter based lesions, then that can also show diffusion restriction. Then if the things like abscesses, if it is a ring enhancing lesion, showing a central diffusion restriction. So abscesses can show diffusion restriction. Okay, so diffusion restriction doesn't mean straight away saying that as an infarct. Okay, fine. Next.
Yes, sir. So this is apparent diffusion coefficient sequence. So the signal is not very hypointense, either in a left temporal lesion or in left precentral gyral lesion. So we can say that this very lesion is not showing diffusion restriction in this case.
Yeah, so stop here. So we have a case referred for as a stroke, and
Yes,
you are
sir.
seeing a lesion, and you have a doubt whether it is having some diffusion restriction or not. So then you should know whether all the infarct will show diffusion restriction.
No, sir.
So when an infarct will start appearing bright on diffusion,
Appearing
suppose if it is occluded now, if you are saying if the patient developed a stroke now,
Yes.
within 5 minutes, if you do an MR, diffusion weighted image, will it appear bright? When it will appear bright?
5 minutes. No, sir. No, sir.
So when it will start appearing bright on diffusion weighted images?
6 hours.
No, 6 hours. If it appears only at 6 hours, then how will you do all the interventions? So it will start appearing bright on diffusion weighted images within
30 minutes.
Okay.
30
Yeah,
20
20 minutes. Yeah, 15 to 20 minutes it will start appearing. Then when it will be maximized, the maximum brightness will happen after 24 to 48 hours. Okay, but it will start within 20 minutes, 15 to 20 minutes. It will be maximum for 24 to 48 hours. And how long it will appear bright on diffusion?
10 to 14 days.
No. Diffusion, it can appear up to 2 months. Okay. So minimum 30 days it can appear bright. Whereas in an ADC, the changes will appear little faster. So when you are looking at only the diffusion weighted image, sometimes it's difficult to differentiate an acute infarct from a subacute infarct. Whereas ADC usually start appearing darker on ADC by 20 minutes, and again will be very dark by 24 to 48 hours. And by 2 weeks time, the darkness will reduce and start becoming brighter in ADC. Whereas on a diffusion, it will remain bright for at least 6 weeks to 3 months time. Okay, up to 72 days, generally people say can appear brighter on diffusion weighted image. Okay, yeah. So if it is appearing not showing diffusion restriction or not appearing darker on ADC, that doesn't rule out an infarct. It may suggest that it may be very hyperacute, which is very unusual in Indian setup. Scanning within 20 minutes, it is likely that the infarct could have occurred more than 10 days before the your scanning. So that is a possibility always you have to keep in mind. Okay, fine. Next.
So, sir, on GRE sequence, there was no blooming, which could be suggestive of bleed in any of our lesions, sir. So, on the basis of our findings on flare and restricted diffusion, one post-contrast sequence, the lesion in left temporal lobe as well as the lesion in left precentral and post-central guidal lesion, that was not showing any enhancement. As you can see in this cut, sir, there is no enhancement in left temporal lesion, as well as the lesion located in left precentral gyrus was also showing no enhancement at all. On the basis of these findings, we have few DDs. This is just a description, sir. Hyperintensity lesion located in left thalamus and in precentral and postcentral gyrus, showing no diffusion restriction. And on post-contrast imaging, there was no enhancement. On the basis of these findings, the DDs for these lesions could be infarcts, arterial all venous, encephalitis, gliomas, metastasis, and lymphoma.
Yeah, so this case, in fact, came to our department some time back, maybe about 10 years back, and during the emergency time. And initially, it is reported by a resident as a infarct. And if you look very carefully, and in fact, it has been reported the lesion showing a diffusion brightness as an acute infarct, and those lesions in the thalamus and the postcentral gyrus hyperintense lesion which is not showing diffusion restriction has been reported as a chronic infarct. Okay, the importance of looking at this lesion is very important, because many times you will as a resident, this type of the lesions you are going to come across during your duty time. Okay, and invariably it will land up only at night somehow. You won't get any senior people around you to help you, and you will be alone at night at during sleeping time. And when you get a MRI like this, and you may think that you'll always go with the clinical diagnosis. And in this case, there are a lot of findings which suggest that it is not a simple infarct, because even the patient had only 2-day history of a weakness, and you'll expect the diffusion under the ADC to be on the highest side, like brightest on diffusion, darkest on ADC, and you won't see much mass effect during that acute phases. Usually only in the subacute phase with the development of a vasogenic edema, you will have a mass effect. Here you can clearly see that the gyral lesion shows there is a bulky gyrus and the effacement of the sulcal spaces, as well as the thalamus. You cannot explain by an infarct. So you cannot have two different locations. So you have to always look at the vascular territory, which vascular territory is confined to MCA territory or confined to a PCA territory, and even the thalamic lesion was appearing slightly bulky. So with that itself, we can clearly say that this is not an infarct and it is a tumor. Can you show the follow-up of the case?
Yes, sir. So after 2 months, there was a follow-up imaging with the brain contrast MRI, and sir, on T2 sequence, the thalamic lesion is appearing iso-intense to gray matter, and
it is significantly increased.
Bit hyperintense screen size. Yes.
Yeah. It is increased. No. The lesion has increased in size, and so the contrast
Yes,
scan.
Yes, sir. I will show. Sir.
Yeah, so basically to show that this case is turned out to be a tumor, the idea of presentation is not to mistake a neoplastic etiology for a vascular pathology. The management is completely different. So if you say it's an infarct, then they will give a anticoagulant and try to do an angiogram and try to do a thrombolysis, which will be very catastrophic. Sometimes in these type of cases where there will be a lot of hypervascularity of these lesions. Okay, so with that, thank you, Dr. Nupur. We'll come to the end of the session. I thank all the PGs, all three PGs,
Thank you, sir.
to showing the good cases. I thank you once again, the IRIA Kerala chapter, for giving us this opportunity. Thank you.
Thank you so much.
Thank you. Yeah, all the residents did well, and all the three cases were of different what to say etiology, because one was vascular, the other was the third case also was little confusing only, but it was very good. And the second case also was very nice. Okay, all did very well. I congratulate the residents who did very well. Thank you so much.
Thank you.
Dr. Venu, are you online? Dr. Venu?
Somebody is asking what is the diagnosis in the last case. It is basically a tumor, and it's turned out to be a multicentric glioma.
Yeah.
So the idea of the presentation is not to go into that in detail. So when you look at that, the DD would have been a multicentric glioma versus lymphoma. Metastasis is not the DD.
Yeah.
No, it's only to say that it is not an infarct, it's a tumor.
Yeah. First, when the second case, when you kept that radiograph, I thought it was going to be a bare orbit, but the roof was
Yes.
only gone. The sphenoiding was seen properly.
Yes.
Dr. Venu?
Yes.
Yeah.
The residents usually mistake that for a bare orbit. So just to
know.
highlight that.
Yeah.
Yes.
Yeah, that is one thing. The first time the spotter would be immediately it will come bare orbit now. Yeah, that is true.
Yeah.
Now here, Dr. Rajesh, actually the three cases now. The suprasellar mass and orbital, and then cortical lesions, intraaxial lesions, and all. Actually, you actually direct the students in a systematic way, in a stepwise pattern, and this is actually the classic teaching now, the teaching style. So that shows that you are a perfect teacher. And also one more thing, the students know about students know you are actually perfect students. Because in between, actually, you made mistakes, okay, and some doubt, some confusion. So all these were there. So that shows that actually you are also perfect, because in the student period, no, naturally that confusions will come. So once you come up with that or overcome that, then only you will become perfect now. So in both ways, actually, it was just like when we take classes in the when we take discussions in the room now. So the same way actually it happened. So it was very nice to see. Thank you very much to Dr. Rajesh and also to all the residents. Thank you.
Yeah. Somebody is asked in the Q&A session how to differentiate arterial and venous infarct. See, arterial infarct will be confined to a vascular territory like ACA, MCA, or PCA. Venous infarct usually won't confine to vascular territory. For example, if it is a superior sinus thrombosis, you will see bilateral frontoparietal infarct. And the arterial infarct, the gray matter will be more involved than the white matter, whereas in venous infarct, we will see a significant amount of vasogenic edema with the white matter involvement. Diffusion restriction may not be there the entire extent of the venous infarct, whereas the arterial infarct, the entire infarcted segment will show diffusion restriction. And the other thing is hemorrhages are more common in a venous infarct as compared to an arterial infarct. And the etiology also is usually different between arterial and venous infarct. For example, the arterial infarct are usually due to atherosclerosis, old age, or thromboembolic phenomena in the cardiac case. Whereas the venous infarct are usually due to the predisposing factors like APLA syndrome or SLE patients, or patients with the say nephrotic syndrome. Those who are prone to develop a thrombosis, they will have a venous infarct. So the age group will be also different, and the presentation and even the patients can present with the venous infarct. Patients can present with epilepsy, like a focal seizures. So these are all very common. Yeah, with that, I'll conclude. I thank you all once again. Thank you. We'll see you next week.
Yeah, thank you so much.
Okay. Good night. Good night.
Good night. Thank you, our MedPiper team, Dr. Soumya, who is online, who gave us this opportunity without any interruption. Thank you so much, Soumya, and thank you all once again.
See you at 8:30 today.
Okay.
Yeah.
Okay. Bye.